Well, I hope this is working. We should be live by now, and that was a really great presentation that we just heard on from some of our surgical colleagues. A great presentation from the orthopedic people, letting us know what to do. So we're going to change topics now. We're going to move over to nerve transfers, and I'm really thrilled to be able to participate in this program. Thank you very much to the organizers, and I'm also thrilled to be able to participate with my colleagues who are going to be speaking afterwards. Who are very, very good surgeons as well. They are going to talk about specifically lower extremity. I'm going to focus on upper extremity, and Dan is going to focus. Amy's going to be focusing on lower, and Dan is going to focus on phrenic nerve. What I'd like to do is give you an introduction to what a nerve transfer is, so we are all speaking the same thing and can follow along. So to begin with, if we think about in general, what's the prognosis for these children, and we've already heard some discussions about that. Really everything has focused on the initial treatment. So CDC, everything like that, talks about how do you manage these kids when they first come in. What we're focusing on is what can we do long-term to help the children. And one of the keys here is the 9-month rule. So initially it was thought that at about 9 months, you're kind of peaking in terms of what you're going to recover. We're thinking that that's actually a little bit earlier now, really by about 6 months, or the cat's out of the bag in terms of whether or not there's going to be significant recovery. So we're starting to get a little more aggressive with our surgery and our nerve surgery, orthopedic surgery, and so on earlier, because we think by about 6 months you can already tell where things are going. So what are some of these options? Well, if we think about the nerve transfers, the one that's the most common and best studied and shows wonderful success is something called the Oberlin approach, and I'll discuss that in a little bit. But we've been really experimenting with a lot of different types of transfers. People have been championing things, other types of transfers for the upper extremity, new types of transfers for the lower extremity, for the phrenic nerve to try to get back breathing. So there are a lot of different things that are now being done for these children, some of which we think are very novel, very new, and some of them which we think are new aren't so new at all. We'll understand why. The phrenic nerve really is something that's being pushed hard to try to get these kids off the ventilator. The intercostal nerve transfer to the phrenic nerve is something that's being done, but pushing the envelope really is any type of nerve transfer to get any kind of axons, some nerve into the phrenic nerve, and then use a pacer to drive it. And we'll talk about that, and I'm sure Dan will address that in detail. So let's get on the same page. What is a nerve? A nerve is a cable. It's an electric cable. It's a very fancy electric cable, but it's a cable. And if you think about it, it's got a thick casing, just like any other electric cable, like the plastic on the outside we call the epineurium. Inside, most nerves are made up of a series of smaller nerves, a series of smaller cables, like a coaxial cable for any of the older people in the audience. And by the way, thank you for all the emails from my patients who have been emailing away. No, I'm not going to be showing any of your children's operations in this talk. People are a little concerned. So the nerve is made up of smaller cables inside, and in the smaller cables inside is something called an endoneurial tube with a single axon. The axon is the equivalent of the copper filament. So when you think of an electric cable, it's got copper in it. That's what conducts the electricity in our cables. In people, in our nerves, it's an axon within the nerve that carries the electricity. So the axon is the key. The nerve is just a supportive structure for all of these thousands of axons. And this is what it really looks like. This is a human nerve that's cut in cross-section. These are the fascicles, or the series of smaller cables. What you can't see, because this is actually without much magnification, you can't see the little dots or the little copper filaments that would be inside. But again, the copper filaments or axons are what conduct the electricity. Why is this so important when we're talking about AFM? This is a spinal cord, and out of the spinal cord is coming a peripheral nerve. The key is that in every nerve, there's thousands of axons or copper filaments, and their cell body, the origin, sits here in the front of the spinal cord. And then it has a projection or a copper filament or an axon that projects all the way out the nerve to the muscle, to the skin, and so on. The key is that the cell body, which is the nourishment center for the axon, is sitting here in the spinal cord. So if we injure the spinal cord, and AFM unfortunately is an injury of this part of the spinal cord, you injure that cell body. And when you do that, the axon or the copper filament degenerates. And unfortunately, it's probably not going to come back. Now, in some children, in some injuries, it's a partial injury and some of it can recover. In other more severe injuries, the cell body is destroyed and therefore no axon can regenerate or come back. In most instances, it's probably a little bit of a mix. Some axons are still partially there, could recover. Many are lost. But the key is this is where the injury is. And again, you have to have the copper filament or the axons to carry the electricity. So if we look out here in a peripheral nerve in a child with AFM or a patient with AFM, the nerve looks just fine on the outside, but it's missing those axons or copper filaments on the inside. If we take an individual axon, one single copper filament, so here's a copper filament in this cartoon and we injure it, what happens is the part that's still attached to the cell body, which was sitting up in the spinal cord, stays healthy. The other part degenerates because it's been disconnected. It degenerates. But the axon, if it's still connected to a healthy cell body, can regenerate, regrow back down. And this is when people start talking about these rules of a millimeter a day or an inch a month. What they're talking about is the ability of that axon or copper filament to regenerate at an inch a month back down the tube and hopefully to a muscle. Here's a muscle to regenerate from the injury site back down to a muscle. Now, if the injury is very proximal, up near the spinal cord, it's a long distance back to that muscle. If the injury is down in your arm close to the muscle, well, then it's a much shorter distance for it to regenerate, and therefore much more likely that that will occur. But the rule of thumb, and again, a lot of these things become confusing when you read the literature, that inch a month rule is the distance or the time that the axon is regenerating. It's growing at an inch a month towards its target. And so that number depends on what you're reading, but let's just say in humans, it's about an inch a month. Children may be a little bit faster. Millimeter a day, couple of millimeters a day, it's in that type of range. Now comes the next one, the 2-year rule of thumb. Why is that so important? When the muscle does not have nerve in it, when the nerve degenerates, and again, when we say nerve, we're really talking about those axons or copper filaments inside. If the muscle doesn't have an axon, then the muscle starts to degenerate. The muscle says, why be here if there's no axon to make me move? And the muscle starts to degenerate. And over time, the muscle severely degenerates to where it can no longer survive. The body resorbs it. In adults, usually by about 1.5 years, somewhere around 14 to 18 months, the muscle is pretty well gone. And even if you get a nerve back into it, it's not going to regenerate. Children do a little bit better. But nevertheless, we feel somewhere around 2 years, we have to have the nerve back in the muscle for the muscle to survive and regenerate. And remember that it takes time, an inch a month, for that nerve to grow back to the muscle. So here, when we look at that, again, typical stretch injury of a nerve, spinal cord, the nerve coming out. If you stretch the nerve out here somewhere and snap the axons or the copper inside, it's got to regenerate all the way back down. If it snaps in two, it's probably not going to heal itself. And if the nerve is pulled out of the spinal cord in a very severe injury, again, it's probably not going to heal. Now, again, AFM is similar to this in that that's where the injury is, way up here in the spinal cord. And if the nerve is going to regenerate, it has a long way at 1 inch a month to go all the way back down out of the spine and all the way back down to the targets at about 1 inch a month. So we think about the children, and we're seeing them now, let's say, at about 4 months of age, already thinking, this child is maybe not recovering as quickly as we had hoped or as well. What are we starting to think? Well, non-operative therapy begins day 1. So we want occupational therapy, physical therapy, working aggressively with the children right away. Operative, primary or secondary. The primary are the nerves. The secondary repairs you've already heard about, which are muscle and tendon repairs. So here's a nerve. It's been divided. Here it's been cut either by the surgeon, by trauma, by whatever reason, and we're bringing the 2 ends of the nerve back together and sewing them back together. Now, when you sew the nerve back together, the nerve doesn't start functioning. If we think of this on the left side being the brain up here, so the nerve is connected, and this is the distal end, we call it, the axon, once we bring the 2 ends of the nerve together, we still have to have new axons grow back right from where we repair it, all the way back down to the muscle. So here at the repair site, nerve is going to start growing on the inside axons. They're going to sprout, grow all the way back down, at an inch a month. So it takes a long time, even on a nerve repair, to get back to the target. Sometimes we have to fill in the gap. We can use cables to do that. But again, the axons, the little copper filaments, have to grow from the proximal end all the way back down to the muscle. And that's what it looks like. This is the typical nerve that's been cut, and we have cables filling it in, and that's going to hopefully regenerate. Now, how does this all play out in AFM? So probably almost 15 years ago now, I was sitting with one of our neurologists at lunch. He was talking about a child he was treating. He wasn't exactly sure whether it was transverse myelitis or exactly what the disorder was, and in retrospect, it may have been AFM. But we talked about the injury, and it sounded to me like a brachial plexus injury, like we normally see with trauma, very severe trauma. So we decided to treat that child the same way we would treat a severe brachial plexus injury, and we did the same nerve transfers that we normally do. And we reported that case, and that started a lot of the work for us on looking at nerve transfers for these kids. So a nerve transfer is basically robbing Peter to pay Paul. What we're doing is we're taking a nerve that is still working, that's perfectly healthy, and we're saying we can take that nerve because there's enough redundancy in the system that if I steal that nerve, you're not really going to miss it. And I use that nerve to power another nerve that we desperately want. So we're robbing from Peter to pay Paul. And if we do it the right way, we can get away with it in most instances where the patient doesn't know that we've stolen something because there's enough redundancy, enough overlap. Now, the good thing is we can do it much closer to a muscle. So if you think about the injury up in the spinal cord, we can go into the arm here and steal a nerve that's perhaps working, doing something down here, and we're going to steal that nerve or part of that nerve and rewire it into a target of a muscle up here that's not working. And hopefully that will work. Now, if you think about it, a couple things have to happen. Normally, whatever that nerve was originally doing, let's say it's bending my fist. Now I'm asking that nerve to bend my arm. I've rewired it, and the brain has to relearn to do that. And in most instances, the brain can do that, but it is asking a lot of the nervous system, and we need therapy to help that. And we can do it close, usually close to the muscle, and hopefully get away with robbing from Peter and not having to pay too much to Paul. So let's look at what this really does. It's not new. Okay, so we didn't discover this suddenly. 1903, Harvey Cushing reports doing these types of nerve transfers to repair facial paralysis. And this is the same concept that we're talking about. So it's certainly not a new concept. And like most things, we rediscover these things, refine them hopefully since 1903, but it's the same basic concept. And I'm just going to show you some typical examples for the upper extremity. So here we're taking a patient whose shoulder is not working. They can shrug their shoulder, but they can't move their arm out. We're taking the nerve that normally shrugs the shoulder, taking part of that nerve and rewiring it into this nerve, the supraspinatus muscle here, suprascapular nerve, such that now when they go to shrug their shoulder, part of it will still shrug, but that nerve is also going to cause it to pull out. So we're doing that transfer. This is the back of the arm. You're looking at the shoulder up here and the tricep muscles down here. And in this patient, what they've done is taken one of the branches of the nerve that go to the tricep, that straighten out, extend the elbow, and have transferred this into the axillary nerve for the deltoid. So this was the original nerve over here going to the deltoid muscle. That nerve gets cut because it's not working. We take a tricep branch that is working and put it into the deltoid. So now when the patient goes to straighten their arm, it'll be slightly weaker because we've taken one nerve, but they'll also be able to use their deltoid and bring their arm up. The most common and the best described is the Oberlin procedure. And it's called Oberlin because of Christoph Oberlin, who described this, and he described it in a 1994 paper. Now, what was very unique here is he didn't take the whole nerve, he only took part of the nerve. And that's what makes this a very different transfer and a very exciting transfer. And I'm going to show you what I mean by that. So this is the Oberlin procedure. Here you're looking at the chest, the ribs, the arm, the shoulder up here. And here are the muscles and nerves coming down the arm. Now, in this patient, they can make a fist, but they can't bend their elbow. Their bicep is not working. And if we look at what's been done, the nerve here, this is the ulnar nerve that makes a fist, and only one of those fascicles, remember the nerve is made up of a series of small cables, one of those cables has been divided and put into the nerve that goes to the bicep. A little close-up of that. So you see here a single cable has been divided. The bicep nerve has been brought down. And now when the patient goes to make a fist, when they're activating their ulnar nerve, they're also going to activate this nerve, which will bend their arm. So they'll make a fist and their arm will bend. And eventually the brain will relearn how to separate those out. So that's a wonderful transfer that works extremely well. This is what it looks like in a person. Here we see the arm opened up, the shoulder is over here, elbows over here. I apologize for the graphics if anybody needs to look away. But these are the nerves and vessels coming down the arm. We've labeled all of them. And then what you see here is, again, the single fascicle. So here's the ulnar nerve. A single fascicle has been brought up, and we're going to connect it to this nerve, which bends the arm. So that's the single fascicle cut. And here it is repaired. A little dab of glue will go on to hold that tight. And that's a single fascicle coming up. So that patient fairly quickly will regenerate axons up to the muscle, because now it's a very short distance. So that inch a month is only a couple of inches here. So usually within about 4 or 5 months, that patient will start to move their arm as they make a fist, and then they'll need rehab and so on to understand how to separate out those motions. So what about the phrenic nerve? Now, unfortunately, we're dealing with a lot of the AFM kids with problems with breathing. We know that. And now we need to get axons into the phrenic nerve. The standard way to do that is to transfer an intercostal nerve to the phrenic, because the intercostal is also a breathing nerve. But what if the intercostal nerves aren't working? We've been taking the spinal accessory nerve, again, a nerve that shrugs your shoulder, and put it into the phrenic nerve. But as I'm sure Dan will address, then you have to pace it, because that's not a normal breathing nerve. But we've also gone and pushed this rather hard in some of our kids, and some of the parents might be on today. We've taken the nerve from the other side of the whole right side. Let's say right side is not working. We could take one of the nerves from the left side, bring it across the neck, put it into the right side, and get it to work that way. So that's called a contralateral, because we're bringing it from the other side nerve transfer. And this is what this would look like. Brachial plexus is here. These are the nerves that exit the spine, go through the shoulder, and control your arm. And this is the shoulder area where these nerves all crisscross and so on. This is a very severe injury. This is a young girl. I'm showing you a particular case. It's not AFM, where all 5 of the major nerves were pulled out of the spinal cord. That's the equivalent of AFM, because her nerves are destroyed at the level of the spinal cord, just like an AFM, which means none of these nerves are ever going to work again, because there's no axons ever to regenerate. So the question is, what do you do in a severe case like this? Now, in this case, her nerve was brought from the other side, the working side. So from the left side, one of the nerves was brought across her neck to reinnervate the right side. It's a nerve transfer across the body. And if you think about that, that means when she's going to move her left arm, her right arm's going to move. So that's a lot for the brain to relearn. This is what it looks like. For example, here's the C7, and that's the nerve we tend to use. The nerve's been cut, we put grafts on, and we're going to bring it across the neck. That also means there's the repair site. Those axons are going to have to regrow now from wherever our repair site is, all the way down our grafts, all the way across the neck at an inch a month. So this is going to take a long time to work. And here's the patient. Now, this is a couple of weeks after her surgery. Her right side is paralyzed. All of those nerves were pulled out of the spinal cord. The operation was on the left side to cut the nerve, put grafts across the neck, hook them up over here, and hook them up over here. And over time, we're hoping those axons will regenerate across and start to control the other side of the body. And the question is this pushing it too hard? Can we really get the brain to figure that all out? So here she is a couple of years later, and she's able to abduct or pull up her now. She's using her what was a paralyzed arm, and she's able to bend her arm, and she's able to bring it all the way up. So she's able to do that. The question is, does she have to move her left arm to do it, or can she independently control? So after a number of years of working with rehab, here she is. And as she says in her little postcard that she sent to the hospital, I'm all grown up and competing on the national level. You may have long since forgotten me, but I always remember you, the Hopkins team, and this is my horse, whose name is C7, which is the name of the transfer. So she was able to, with her brain, relearn that. So we can push our AFM kids, which is a very similar injury, pretty hard. How novel is this? What are we doing, and how extreme can we get? This is the final case. This is a polio-like syndrome in a 15-month-old child. This was a patient who was operated on here at Johns Hopkins, had fever for 2 weeks, followed by weakness of the limb, no sensory changes, sounds like polio or AFM. And went through a series of surgeries, and these are the surgeries that are very typical of what we're doing. C5 and 6 are out on physical examination, lower extremity sciatic nerve is out. And what was done? Nerves were explored, and a series of surgeries were done. And basically, in the upper extremity, the spinal accessory nerve was transferred into what's called the upper trunk to try to get back an elbow that bends. So that was a transfer that way. And in the lower extremity, the obturator nerve was transferred to the femoral nerve, and another nerve called the interfemoral nerve was also transferred over to the sciatic nerve. So a series of nerve transfers were done in this child in both the upper and lower extremity to treat this AFM polio-like syndrome. And the question was, yes, it was done at Johns Hopkins, and this surgery was performed by Harvey Cushing in 1904. So once again, while we think we're doing new things, in fact, we're really rediscovering some of our forefathers, so to speak, work that was done. We're refining it. I think we do it a lot better than they did with a lot more technology, but the concepts remain the same and they work. And this was the paper that we had published on Cushing's patient from 1904. So in general terms, I think this works. I think we have lots of things that we can offer the children. You're going to hear from Amy Moore about how she's been pushing the lower extremity. We've been working with her on that. You're going to hear from Dan how we've been pushing phrenic nerve and trying to get people to reinnervate. There are a lot of things that we're doing here that are very, very exciting. And our next speaker is a very exciting speaker. Why is that not working? I want to introduce Dr. Amy Moore, a good friend who's going to talk about what she's been doing with the lower extremity.